So we'll give it a minute or two for people to be added in as quickly as Maria and Thériault can do. So we'll give it another 10, 15 seconds here. So hello everyone, I would like to welcome you to today's special OC3PR, which will be discussing a very challenging but incredibly important problem of how do we ramp up and begin to recover from the impact of COVID-19. For those not familiar with OC3PR, it's an educational and informative series sponsored by Critical Care Services Ontario. Its emphasis is on critical care issues, both direct but also indirect, including patient care problems, but also on staffing and overall management issues. As before, there's an opportunity to submit questions to the name Q&A, which will be fielded today by Dr. Bernard Lawless and hopefully Dr. Mike Sullivan. As always, please keep yourself muted. Remember to fill the survey at the end of the webinar, as it helps us make these presentations better, and it also helps us demonstrate the benefit of this webinar series. We also hope you can follow CCSO on Twitter and YouTube. As we have been managing the impact of COVID for over a year, I'm sure many of you are like myself, are very tired. I know our staff are tired. Often we use that word burnout to describe it, but it's something different, something more. So as this third wave begins to subside, talks of how we will ramp up and increase elective or non-COVID activity are both necessary, but also met with great trepidation. I think many of us recognize the gravity to ask the same staff, including those who had been redeployed to various locations because of COVID, be it to critical care units, but also assessment centers, vaccination centers, long-term care facilities, and other places. You can imagine that to ask them to do more to help us catch up on a perceived backlog, I believe is not without problems and consequences. You can see we do this live and we get our own overhead announcements, which really make it interesting for whatever we do. Apologies for that. I think as well, when we look at last year, when we had our first ramp up, which to be honest was very protracted and I believe was troubled with various problems and challenges, it increases the difficulty of what this ramp up will be. Add the fact that summer is coming, it makes this burden of having an effective ramp up that much greater. And what most appreciate is the consequences of this has profound effects. How do we do it? How do we do it safely? How do we do it more fairly? How do we do it effectively? These are but few of the many questions that come to mind. So we are extremely fortunate to have with us today Dr. Chris Simpson, who will be having a major role in tackling this problem. Dr. Simpson, as many of us know, is well qualified, having held or presently holds various leadership roles. He completed his medical school training at Dalhousie University and went on to complete internal medicine training, cardiology training at Queen's University. He subspecialized in cardiac electrophysiology and founded the Heart Rhythm Program at what was then Kingston General Hospital. He is a professor at Queen's University and has held many roles at Queen's and Kingston Health Science Center, including being the clinical vice dean, the medical director at KHSC, and was the director of the Southeastern Ontario Academic Medical Organization, or CMO. Chris was the president of the Canadian Medical Association in 2014 to 15 and has been a chair of a number of health-related programs. Presently, he currently sits as the chair of Ontario Health's Quality Standards Committee and last year was appointed clinical science lead of the Ontario Health COVID-19 Oversight Table, where he has led the development of clinical guidance on personal protective equipment, assessment centers, and health system restart and maintenance. So clearly, Chris, you like challenging and even so-called wicked problems. Dr. Simpson, I'd like to personally thank you for taking the time today to speak with us on this incredibly important topic and even potentially contentious issue of the so-called ramp up of our health system. I look forward to hearing your sage insights on this issue, and I'm going to pass it over to you now, Chris.
Well, thanks very much, Dave, and thank you everyone for the kind invitation to speak with you today. I just want to start by thanking you all for the outstanding work you've done and that you're continuing to do, and as Dave alluded, will continue to be asked to do. I'm not a critical care doc, but you know, I've never been so proud in my whole career to have colleagues like all of you through such a difficult time. So I think we can advance a couple of slides, Maria, to the outline slide. What I thought we would do today is to talk a little bit about some of the health system recovery work that's underway, and then talk a little bit about how we're thinking about the pandemic-induced care deficit. So this notion of the backlog, which has a lot of political time bombs and other inflammatory rhetoric embedded in it, and just unpack that a little bit. And then a little bit about the recent resumption of some of the deferred activity that's just getting underway and what we think that's going to look like in the coming weeks. And then afterward, I hope to hear from all of you to learn where you think the critical care community is going in the future, and what you think you need from us at Ontario Health in order to be successful. So we go ahead to the next blue slide, and we'll just pause here for a second. So just to set the stage a little bit to talk about recovery, I think it's important to remember that we did do some recovery from wave 1 work last spring and summer. And we produced 2 specific guidance documents for the field. The first was a restart after wave 1 document that spoke to getting us up and running after the severe shutdown of so-called elective procedures that Directive 2 then mandated. And as Dave said, it was a very severe and blunt instrument. Activities diminished to something like 10%, and then it was a very protracted recovery, leaving a lot of capacity on the table. And I think everybody recognizes that that was, you know, could have been done better, although at the time, I think we have to recall that this was uncharted territory. Nobody knew what was coming. There was a lot of concerns about PPE. It was a bit of a different landscape, and so the reopening was extra cautious. And so because of that, we generated further guidance that we called optimizing care through different transmission scenarios, where, and we did this work pre-wave 2, anticipating that there'd be more COVID pain to come. But we very much took a dimmer switch approach to activities depending on the state of transmission in the community. So at that time, we were certainly anticipating wave 2, but we had no real crystal ball around, you know, the fact that a variant-driven wave 3 was coming, or that wave 3 would come right on the heels of wave 2, with CRCI numbers starting at 400. But it did allow us to avoid the huge care deficits in care that we had accrued in wave 1, and I'll show you that a little bit later. So let's go to the next slide. So in any case, with wave 3 now receding, we're refreshing the recovery work that we had started just before wave 3 hit, with the knowledge that vaccinations are rolling along nicely now. We seem to have a reopening plan from the government that's cautious and generally reasonable. So if we can really drive the COVID-19 numbers to the ground, and we can get to the point where you know, contact tracing is actually working, and we've got things under reasonable control, then we stand a good chance, barring any new variants or other curveballs, of imagining a more manageable COVID-19 experience going forward. So this slide kind of shows in broad strokes how we're seeing recovery, with the idea that we map our activities and work plans to these 4 buckets. So first, there's stabilize, the stabilize phase. And this is about things like workforce stabilization, which would include getting people largely back to where they're supposed to be, getting them some vacation time if possible, support to start to address the burnout and the moral distress that's been experienced, and so on. And it's important to note that the shortness of this bar on the timeline in no way means that we'll resolve these issues over this timeline, but that we'll get to some sort of steady state or approaching some sort of steady state with respect to our healthcare workforce. And over this time, stabilize also means lifting all the temporary measures and emergency orders and so on that we've put in place. All these very unusual things that we've had to do to keep the system afloat. This is the time when we gradually unwind all these measures back to something that is going to get us to some sort of functionality. And that's where restore comes in. So restore is all about functioning normally again, or about restoring functionality of the system. So where the pandemic has adversely affected care, all the deferred care, for example, we need to build that back. So this is where the backlog lives. This is the series of actions that takes us to a place where we say we have a functioning healthcare system again. And importantly, this doesn't necessarily mean that we have recovered all the deferred care, but just simply that we have a functional system in place, that we're not functioning under these extraordinary measures that we have been for the past number of months. It's the point where we're confident that we have the structures and the capacity planning in place to move forward from crisis mode. The orange bucket, or sustain, is all about sustaining some of the things that we've done that we want to keep. So the IMS type environment, for example, the strong regional tables, that sort of slightly more directive organizational culture that has allowed us to get things done rapidly. The whole functioning like a system, or the hashtag Team Ontario thing, and the virtual care gains, these things that have kind of come into being as a result of the pandemic, I think this belongs in the sustain bucket.
Oh, I forgot. It wasn't crying with it.
I think somebody. Can you hear me okay? Still
yes,
good?
It's been fixed now. Yes, thank you.
Oh, okay, great. So then the purple thing, the purple bucket is the transform bucket. And that, I think, is the most important one. We have to believe, I think, that all this disruption that we've had has to lead us to a better place in the end, because it would be really unfortunate to waste the crisis that we've had to endure and the opportunity for change that crisis has created. So many things live here, including so many of the inequities that the pandemic has exposed with all its sharp edges. How can we serve our citizens more equitably? So everything from central wait lists to fundamental funding formula changes live here. OHTs live here. Better, more timely data for healthcare professionals, for system leaders, and for policymakers all live here. So the bottom line is we want to build back better, to steal from Joe Biden. The opportunity to navigate historical barriers to change better than before is absolutely there. I think we'll all have to work very hard to keep this transform bucket alive and well, because I was talking with Dave and some other folks from your group a couple of days ago, and we talked about what a huge attraction there's going to be for all of us to retreat to the psychological safety of the old status quo. We just all want to get back to the way things were, but we'll need to resist this to some degree, and we need to embrace the uncomfortable feeling that comes with change. And that's something that I think we need to prepare for. The pandemic has not only taught us how fragile the system is, but it has also exposed the deep inequities that have shown us how not all Ontarians are treated the same. Your postal code matters. Your ethnicity matters. Your income decile matters. Where and how you work matters. Whether or not you speak English as a first language matters. So we've seen all this, and society has seen all this. And if we can't commit to fundamental changes now, after all we've seen, then we never will. So this is our chance, I think, for a once in a generation leap forward along the healthcare transformation agenda that we've all talked about and all agree on, but have never been able to do. So the transform bucket is going to take some ongoing restlessness, I would say. And it's going to take advocacy, and it's going to take pressure. And it won't come easy. But now's the time to stop talking about it and start doing something about it. So on to the next slide. As we dip a toe into the stabilize phase, the first step has been the rescinding of Directive 2. And you'll recall that Directive 2 was the order from Dr. Williams, the Chief Medical Officer of Health, that had directed hospitals to cease all non-urgent, non-emergent activities. So now that Directive 2 has been rescinded, there was a memo that came from the CEO of Ontario Health allowing for some of the deferred surgical and procedural work to resume. And in issuing the guidance to the field, we began with a few assumptions. First of all, there's an assumption that hospitals across the province will continue working together as an integrated system. Your group knows the value of this, I think, more than any other group. And we were able to function as an integrated system better than at any time in our history. The transfers alone kept 5 or 6 hospitals from going underwater. And I think when the story is written on the pandemic response, that collective response is going to be, I think, our finest hour. So functioning like an integrated system means that for the moment at least, the IMS structures will still stand. Transfers will continue, although they will be at a diminishing number. And the transfers will, I think, be over shorter distances. So we're going to see fewer transfers from Scarborough to Kingston or from Lakeridge to Ottawa, or those kinds of distances. I think we'll have this kind of reverse concentric circles sort of thing. We've assumed in our planning that continued capacity for COVID is going to be required. We can't fall into the trap of believing that COVID is going to be over as wave 3 diminishes. The best case, of course, is that it's reduced to an endemic virus with little flares here and there. But even as numbers diminish, there's still going to be outbreaks, there's still going to be hotspots, and a significant inpatient COVID imprint is going to be there for some time. And again, nobody knows this better than, than all of you. So we can't presume at all that we are beyond COVID, and we certainly can't presume that there can't be a wave 4. I know nobody wants to think that, but we can't be certain. So we need to have ongoing COVID readiness. We've also assumed that there will be a focus on equity and reducing health disparities, and that will be a central part of our decision making. We've assumed that because communities and the healthcare organizations that serve them have been impacted by COVID asymmetrically, we'll need to ensure that harder hit communities will be prioritized for support. And following from that, it's clear, we think, that the actions and the resources required to resume surgeries and procedures will vary between communities. There will be some who can start tomorrow. There are others who will not be able to start at all, and everything in between. And finally, and importantly, the health and safety of patients and caregivers and healthcare workers will need to continue to be prioritized through diligent IPAC and public health measures. So on to the next slide. So as we began thinking about recovery for surgeries and procedures, I'd like to just review the following things. So first of all, what is the pandemic-induced care deficit? The notion of backlog, I think, has been grossly oversimplified, and I'll get into that in a minute. A gradual ramp up of activity, In the early days, we need to ramp up slowly and carefully, and we'll need to monitor all the data very carefully to ensure that the third wave really is on the wane and that hospitals can absorb the increase in activity. I'm very interested not so much in restoring volumes, but rather in ensuring that we have performance. So in other words, we'll be monitoring the percentage of patients whose care is delivered within recommended evidence-based wait times, not so much recovering historical volumes. And the reason for this, I think, is that in order to get on a list for surgeries or procedures, you first need to be diagnosed with something. And with primary care having diminished, with presentations to the emergency department being reduced, with diagnostic testing having been reduced, we know that a lot of patients are stuck upstream in their care trajectory, undiagnosed. And as a result, the real possibility exists that if we were to pour all kinds of resources into getting surgeries and procedures running at, say, 110% of the normal run rate, we're going to find that we have no patients. And I'm not exaggerating, because we certainly saw this in the cardiac procedures after wave one, where even though procedures were severely curtailed and the numbers were way down, over the summer, the wait times were actually lower than normal. And that's because there were fewer patients being onboarded onto wait lists. So that may not be the case for things like cancer, but it may well be the case for many other surgeries and procedures. And that's one of the reasons why I think this 250,000 number that's often quoted as the size of the backlog needs to be nuanced a little bit. A focus on bottlenecks and preventative care, upstream and downstream in a patient's healthcare experience or trajectory. So we need to have a close eye on this phenomenon of the missing patient, those patients stuck upstream in their care trajectory, and also downstream. We have about 10,000 long-term care beds that have essentially been taken out of the system in Ontario because of the new IPAC guidelines. No more 4-bed rooms, for example. And so ALC patients are going to be on the rise as a result. And medicine units just continue to grow in every hospital. And of course, all of this through the equity lens. So if you can flip ahead, Maria, a couple of slides. This is a really nice visual. Just one more. There we go. So this is the percent of actual volume of surgeries and procedures. Now, this excludes cardiac and vascular stuff because that's held by Core Health. But for everything that Ontario Health monitors, the first vertical red line is the beginning of wave one, and the institution of the first Directive 2. And the language there was stop all elective procedures. And you can see that the vertical line at 100% is what we had done last year. And then the area under the curve that's colored in blue essentially is the number of people who didn't get their surgery or procedure done. So wave one had a huge impact, as Dave said in his intro. And then the second vertical red line is when Directive 2 was lifted. And that lazy slope back up towards 100% was really very slow. It took us a long time to ramp back up for various reasons. And then we never really were able to get back to 100%. And the reasons for that are all the reasons you can imagine, including, all of the new IPAC guidelines. Patient flow is impaired for all kinds of reasons. And all through the summer and fall, we never really get back to 100% overall. And then toward the right-hand side of the figure, you see the impact of wave 3, which is still being written. So this is kind of a nice way, I think, to look at the care deficit, let's say, fully recognizing that not everybody who's inside that blue is actually on a waiting list for all the reasons I described earlier. But this is the delta between what we did last year and this year. The next slide I've always found kind of encouraging, and that is that after wave one, The recovery from wave one is sort of on the very left side of this graph. And we didn't do a very good job in wave one because we ramped down even the P2 procedures. So P1 is emergent, for those of you who don't know, and then P4 is the least urgent. This is how surgeries are classified. But over the summer, we actually did much higher rates of P2s and P3s than we did the year before. And this was at the expense of the P4 procedures, which in a triage environment is what you would want to see. And then again, over at the very end, we see wave 3 hit. And even in wave 3, we were able to protect the P2s, but the P3s and the P4s started to go down again. So some confidence, I guess, that unlike in wave 1, over last summer and fall and through wave 2 and into wave 3, we managed to keep the P4s, the P2s, and to some extent the P3s going. So it's making the best of a bad situation, I suppose. And the next slide shows that the care deficit is not the same across the board. So this represents the cancer surgery care deficit, excluding skin cancer. And you can see that the amount of blue here is much less than the total amount of blue in the overall picture. So again, in wave 1, there were a lot of concerns that the ramp down was extreme and that we probably didn't do procedures in a timely way for some cancer patients in a way that actually probably made a difference for them in terms of prognosis and outcomes. Again, didn't quite return to 100%, but sort of settled in at around 95% of last year's volumes, which is, pretty good, or at least not horrible. And then wave 3 has, another little blip. Again, not to just diminish the importance of deferred cancer care, but the magnitude of the ramp down for cancer care overall is not as much as it was for surgeries and procedures in general. And so that seems appropriate. The next slide is some interesting data on the distribution of the estimated pandemic care deficit. So there's that 250,000 number that you've all heard, which is basically the area under the curve, that blue area in the first graph that I showed you. And as you cast your eye across this, you can see that an awful lot of it is ortho, as you would expect. An awful lot of it is cataracts. A lot of it is gynae surgery, so mostly the benign uterine surgery, and general surgery, a third of which are hernias. And then over in the last column, you can see what they've estimated the ICU footprint of these deferred procedures to be. So some of you may take issue with these exact numbers, like that ortho number may be a little bit low, but it kind of gives you a sense as to the numbers of what's in that care deficit and the magnitude, and then the potential ICU footprint if all of these, suddenly are going to be done over the next little while. So we can skip ahead a couple of slides. Our current state, as I mentioned earlier, Directive 2 for healthcare providers was rescinded on May the 19th to enable hospitals to gradually resume non-emergent and non-urgent surgeries and procedures, provided that some criteria are met. And we've required hospitals to start resuming this activity as long as it's not expected to require inpatient resources. So this is our first kind of launch out of the gate while we're still watching the data very carefully. We want to make sure that the numbers are still coming down before we take all of the governors off. So this allowed, day surgeries to start again. The IHFs, the independent health facilities are started up again, and so on. And the beauty of being in OH memo land instead of Directive 2 land is that, we can be much more nimble. And so as we see that things are continuing to improve, we can rapidly go to whatever the next step is, which might be, let her rip, everything starts going again, or there may be some interim steps along the way, depending on what the numbers show. The next slide shows the criteria for gradual resumption. So we've said that hospitals can resume non-urgent and non-emergent procedures that don't require hospital inpatient resources, as long as there's a plan in place for how the hospital will incrementally create capacity for staffed adult inpatient beds to care for both COVID and non-COVID patients. HHR has to be available. We all know this is the big rate limiting step for all of this incremental planned activity. And it can't be done at the expense of urgent and emergent stuff, obviously. Very importantly, the hospital needs to continue to accept patient transfers as directed by the IMS structures. So the answer to a request from the IMS cannot be no because of ramp up. The hospital is committed to continue collaboration with regional structures to support a provincial approach to health system capacity, that the supplies are sufficient to meet both the current usage and projected requirements, and the diagnostic and supporting services are present for resuming this activity. So the diagnostic imaging, the pathology, the transfusion medicine laboratory, blood bank, etc. So where all those conditions are met, then that startup has begun. So next slide. So we'll be keeping an eye on changes in activity, on case counts, on hospitalizations, etc. And we're prepared to issue subsequent memos in short order, perhaps as early as next week. So the intent really is to be as aggressive as we possibly can be in getting care ramped back up. And then finally, the last slide, it does look like we'll continue using the IMS structures and transfers to support the hardest hit hospitals for a bit longer. We can go to the next slide. But after that, our attention will be turning to ICU bed capacity in the future state. And one of my colleagues from the executive senior leadership team at Ontario Health, Otto Kalfan, is here, and he and his team are leading this work and are doing some modeling work in partnership with the ministry. The idea is to help us understand what the numbers and what the distribution should be. So the government, as you know, has committed to making incremental ICU beds, incremental funded ICU beds a reality. And so the challenges, of course, are going to be, how do we staff these? What are the supplies going to be needed? So you'll be hearing a lot more about that very soon, as there's lots to be considered, as you all know better than I do. But we'll need to consider, as part of this planning, a number of factors, including foundational to jurisdiction principles. So just the straight, population calculations. We'll need to layer in consideration for centers with tertiary and quaternary care programs that have special needs. We'll need to project community growth over time. And then we'll need to figure out future surge and pandemic capacity as well. And all of this may well mean that where the beds are now may not necessarily be where they're going to be in their final state. But as I say, more to come. And the goal certainly is to maintain these extra funded beds going forward. So I'll stop there, Dave, and would welcome a conversation.
That's great, Chris. I mean, there's so much there. I don't even know where to start, where to go, and I have a couple of questions, and we'll go to Bernard for some as well. Certainly, the last thing that you did, sometimes the most recent is the most fresh, is in terms of the beds. Now, Critical Care Services Ontario has done a lot for projections and for numbers, and so certainly I'm sure you'll work with them. I guess the challenge will also be what type of bed, ICU beds and critical care beds. So that it'll be interesting how that will be undertaken, because I'm sure it's not as simple as we're going to keep beds here and there, and there's ways of going from level 2, level 3, and maybe we even start creating level 1 beds out there. Might be a way of addressing it. One of the areas I wanted to dive in with you before we go to Bernard is your comment about status quo. And I think, I agree with you 100% that the resistance to change is going to be very high. Everyone's going to have their own priorities and perceived priorities of what's important. how do you foresee that changes to the status quo or how we deliver healthcare? Who's going to decide that? Is that going to be the health teams that have been introduced? Is that going to be Ontario Health? Like, how are we going to create these? Who's going to decide these changes, and how would you foresee that these changes get implemented in some fashion?
Yeah, it's a great question, Dave, and I think past attempts at healthcare reform have not been able to answer that question successfully. And what we're trying to create in our recovery plan is an Ontario Health generation of the goals we all want to achieve together, sort of these high-level goals. And then the regions would be responsible for the how or the implementation, because I think we have to recognize that we can't have a one-size-fits-all sort of implementation plan. What works in one region will not work in another. So you probably know that there are now going to be 3 chief regional officers overseeing the 5 regions. And then underneath there will be, sub-regional tables. There's going to be further development of the OHTs, which have sort of a more, or it's hoped that they'll have a more kind of holistic look at health involving community agencies, primary care, and so on. And that they'll be able to implement the goals that we want to achieve. So for mental health and addictions, for example, we may have a number of very high level goals that address the opioid crisis and address access to community services, for example. And then, how that is achieved will be determined locally, but we'll have a central report card which will say, have we met our goals, yes or not. And the other lever, of course, that Ontario Health will have is distributing funding. And the funding will map to the achievement of these goals. So that's sort of a general answer to your question. But I think one of the things we want to do is really create strong regions that have a slightly more directive kind of vibe, so that it's not just a coalition of the willing, kind of doing whatever they want, but not taking away their autonomy and the local knowledge to make things happen as only they do. But we have to have some sort of a North Star that we're all headed for together.
Excellent, thanks. Bernard, I'm going to call on you as one of the hosts of the questions.
This is probably thanks, Chris, for those that presentation, and David for your starting off on a Q&A session. I think this is a bit of a synthesis, I guess, of a theme of a few questions that have been coming in, and it's when we speak to the regional disparity, and I know this is a bit of a it's a challenging one in a sense, because it's difficult for people on the ground, I think, to grapple with the concept of ramping up and how quickly one organization may be able to ramp up versus how, and you've alluded to this, how another may be able to ramp up right away or more quickly. And some disparity, and especially in terms of around the capacity leveling that's been done, and the hospitals who participated to really take patients when they were needed to, but then end up themselves being overloaded and them then not being able to ramp up as quickly. There's that element of, and I guess the best way to sort of characterize it, the way people describe it, is unfairness in a sense. And I don't think we want to get too deep and muddled in that, because we have to kind of see a way through it and, keep moving on, as opposed to getting into the nitty gritty of what's exactly fair and what's not. It's kind of like we've been in a pandemic and none of it's really fair when you think about it, but there is a lot of questions that come forward about how then do we have hospitals sort of ramping up, and some not feeling like they've been slighted because they participated to some strong extent by taking patients and filling up their capacity, but now not being able to ramp up as quickly as maybe some of their other hospital sites.
Yeah, it's you've articulated it beautifully, and I think one of the starting points is let's find sort of the source of truth on this to start with, because there have been a lot of hard feelings. I think that some places have really ramped down a lot and have taken a lot of patients from some of the more hard hit areas, but that the hard hit areas, they kept doing some procedures. And while there are certainly some one-offs here and there, we've looked at these data very, very carefully, and it appears that when you compare it to 2019 volumes, the net sending centers all did ramp down relative to 2019 below the average of percentage ramp down. So all of these sending centers are below that average line, and more than a smattering of receiving centers are above that line. So they didn't ramp down as much as the sending centers. So when you look at it graphically, and we'll put this all together to show everybody once we get it all finalized, but the picture is really one of a system that for the most part, functioned as good citizens. And so, it's never perfect. And I'm sure we can always point, well, I heard a hip was being done here while we're canceling everything, at our place. There will always be stories like that. But the data are pretty compelling that overall, the system did what it was supposed to do. So I think, if we're going to ramp up successfully and recognize some of the asymmetries in the ability to ramp up, we need to sort of maintain that trust that we're here to achieve equity for Ontarians, and for centers that aren't going to be able to ramp up as quickly, they may need some extra help, and that's what that strong regional oversight is about. What exactly that's going to look like, I'm not sure. I'm sure we won't be able to achieve complete equity, but on the other hand, it really makes no sense to hold everybody else back who are ready to go because some aren't. That doesn't mean we take our attention off those who can't. But we can't have a crabs in the bucket mentality where everybody has to stay down until everybody can rise together. So I think we deal with the inequities as best we can, but we can't continue to allow the care of non-COVID patients to be impaired for any longer than is necessary. So we can't leave capacity on the table.
Okay, back over to you, Dave.
Well, maybe I'll follow up on that then, Chris. I mean, certainly I think I'm worried about certain centers that have really taken a hit with the number of COVID patients they have. And I take it you foresee that the regional oversight will help ensure that the patients in those regions you'll never have equal access no matter what we try to think we can do, but a reasonably similar access? Because I asked this because I heard you say that the IMS will not continue indefinitely, and I'm just wondering, how do we achieve that balance once the IMS is gone? Do you see it as this regional oversight, this one of three individuals, or is there another way of doing it?
Yeah, I think it's likely that the IMS based transfers are going to continue. I think for the next little while. I could use a hamburger. Are going to continue for some time, and we just have to remember that the IMS structure was intended to balance out the asymmetrical COVID burden. So as long as there's an asymmetrical COVID burden, I think you can make the argument that that the IMS based transfers should continue. But once that's diminished to a rump force, then we should be back to where we were before. Now, there were asymmetries before as well, but if the COVID induced asymmetry is reduced to a rump force, then I think you make the argument it's time for the IMSs to retire, and the regional and sub-regional oversight tables to then take responsibility for using the levers at their disposal to enhance the more hard hit places. But again, if the COVID footprint is reduced considerably, then the discrepancies in ability to ramp up should be diminished as well. But we'll just have to see, right? None of us have ever done anything like this before.
Yeah, I know. I'm very sympathetic. There's no simple solution for that. Your term you used was transform, was the bottom part of that multicolored bar graph that you had. I almost see that transform as a way of innovation. And I think, we always use that term pretty loosely. It's almost a cliche now, but it will be very important going forward with it. Now, if I take off my critical care hat, I'm also an anesthesiologist, and I see other possibilities with how that can be transformed to help increase activity and help address it. Who would someone bring innovations to? Is that to Ontario Health? Is that to that overseer? Like, how do you foresee that innovations and changes will be presented and brought about? I know we all say, if you give us more money, let's be honest, there's no more money. It's how are you going to save us money, and we'll make changes. But who do you bring changes to, and how do we make them happen?
Yeah, it's I think it's a combination of things. So there will be some innovations that are, you know, local or regional, and work locally or regionally to achieve, you know, the goals we've all agreed to. And those would be something that wouldn't necessarily come to OH or to government. They would just sort of be the way that you've elected to implement the plan in order to achieve the goals. But there might be some things that Ontario Health or the province can do to facilitate our ability to achieve some of these goals. So things like single entry models for high volume procedures. So we might be able to you know, facilitate the software and other planning around a common wait list. Virtual care services is the other thing that we might be able to you know, advance. And particularly in our discussions with the negotiations branch to make sure that virtual care codes of the future in the current negotiations align with the investments that we're making in some of that technology in order to allow virtual care to continue. We might be involved in some public awareness campaigns, you know, to encourage people to, you know, to come to see their care providers. Like we saw quite a reduction in the number of people presenting to emerge with chest pain, for example, for about a year after wave one. That's why the cath lists are down, because people aren't being diagnosed with angina. So, and I'm sure you've all had patients who don't want to come to clinic, or you know, are reluctant to come to hospital. They're reluctant to come to their family doctors to be screened. So there are some things I think that can be done centrally to provide some of the tools that we all need, but I would expect a lot of the innovation to be local and regional, and that's really the vibe we're trying to create is you know, local and regional implementation, but we're all focused on the same set of goals.
Thanks, Chris. Bernard, I was wondering if you had a few more questions there.
Yeah, I think this is again, like I don't know if it's none of these are easy. I don't think so, and probably none of them are black and white. So I think, though, just worthy maybe of a comment, especially I think in the context of some of that regional oversight and having, as the IMS structure can ebb and the regional structures are in place to have some of that oversight. There's almost a sense then that there would be, and I think you allude to this a little bit, and it's a way about how we do things differently going forward that's more responsive and nimble to the system, and taking forward, you know, what we've learned through all of this experience, but also leveling, I guess, of some, either where services exist or where capacity exists in the system, but where there may have been another dominant, you know, within a given region, there may be a dominant player, that there's an opportunity to maybe kind of level set across organizations where capacity exists, but maybe because where there has been a dominant voice at a table, for example, that one center has sort of been, quote, the chosen one sometimes of some services, especially those services that are volume funded and are sort of based in that sense. Is there anticipated, I guess, that there would be a sense of a greater leveling so that patients have access to resources where they exist, and not just where there's been maybe some house, as it was put, I guess, in one of the questions, an empire sort of created around some sites?
Yeah, I think I would agree with that, Bernard, what you're saying. And the hope is that you know, a strong regional structure, you know, unlike the previous LHINs, which was really just a federation of hospitals, right? They never really attempted to direct anybody to do anything. The idea with the regions is to say, you know, look, let's see where variation makes sense for patients, and it might in some instances, and let's see where it doesn't make sense. Where have the empires just been built for no other reason than just raw political power, or the loudest voices kind of carried the day? And, you know, if we can move a little bit more towards the funding follows where the patient needs to be, instead of, you know, funding attached really hard to an institution, which then in turn drives where patients need to be, not based on their need, but where the money was. A stronger regional oversight of that kind of thing, I think, will start to move the bar in the direction that you're suggesting. And again, if the North Star is how are we going to deliver the best care to patients in the the most fiscally responsible way that we can, in the timeliest manner and in a safe way, then the answers become clear. And so we can't let the funding model dictate all of those things. We have to let all of those things dictate the funding. So my great hope is that the regional structures will have that kind of oversight and that kind of influence, to create that kind of change.
That's good. We'll go back to you, Bernard, and do sex. In terms of the regional, is there any idea? I always worry then we start getting sub-regional, and how far down does it go? Any idea when some of that information will come out, Chris? Like, so people, when we're trying to figure out the future for various areas, and like where's critical care going to go in my region and things, any idea of when that will become a little more clear for us?
I think the timeline, Dave, is probably weeks, I would say, not months. You probably know that the chief regional officers, all of those jobs are going to be competitive. The East and Toronto have been put together. The West and Central have been put together, and then the North stands alone. I believe that's sort of the way that it's been put together. But there will still continue to be 5 regions. So what things look like underneath that, I think, will develop pretty rapidly. But first we have to get those CROs in place. So a little bit of a wait, I think, until the structure kind of underneath the CROs is fully elucidated.
Okay. Bernard, you're doing pretty good there. I don't think Mike is with us, so I'm not sure if he has any questions or.
Just from this perspective, nothing much more coming in. And I think it's a great discussion so far, Chris. And I think, again, very important. And I think it almost faces into what people have as immediate concerns about, ramping up, and how do they scale back on sort of what they had to do to accommodate extra critical care capacity, but then now being able to take people who are redeployed back to sort of their other services in the hospital, and what that fine balance is for that. Keeping in mind that we still have quite a few CRCI numbers, so this will be a very gradual process, I believe. But then also some of the comments, I think, sort of looking further ahead about what's is the envisioned as the support that would exist at a regional level in terms of as we move to hopefully a improved system that we can take some of the learnings from the last few months or last year forward. So not a real question in that, just a comment.
Well, I think, one of the things I'm still struggling with, and I think it's just going to be one of those, you balance it as best you can and muddle through as elegantly as possible. But do we, basically the question is this: do we ask critical care to continue with some of these stretch staffing models and these very unusual sorts of things that you've done, and you've done very well, but you're clearly in non-traditional space? Do we get you to maintain that kind of stuff so that we can pull back staff and really accelerate the other stuff? Or is it necessary as a matter of first instance to get your staffing models back to where everybody feels comfortable? I'm using that word again. Does that have to happen as a prerequisite to liberating those staff? And again, I don't think there's an answer, but I'd just be interested, Dave and Bernard, in your views on that.
Well, I think it's almost I guess the other option of that is not just an either or, but also how much of it can happen a bit in synchrony together, where you're sort of scaling back a little bit. The challenge, I think, is going to be around, when you think about where it's reliant on HR, and everybody knows this, is that, the HR complement that we had going in, some people say was already challenging in terms of being able to roster up enough staff to run whatever beds people were accountable for running in critical care. And now we're in a state probably where, as looking at a critical care workforce sort of on its own, there's going to be some attrition from that, given sort of what people have gone through and their, what we can expect. But there's also going to be some people who've experienced critical care like they haven't before, who will want to work in critical care. So there'll be an opportunity to, I think, to build on that. The question is, like, how do you balance that across all services in the hospital so that, those other services can resume some of their activity, and at the same time looking at some of the models that we've used in critical care, what kind of models are actually sustainable on a go-forward basis, and for how long? And is that what the actual horizon looks like in critical care in terms of some of those models that were used to help sustain some of the expanded capacity that we had? So I think it's clear that, as you say, like, there's no one right or wrong solution, or there's no one right or wrong answer to that. But I think these are things that have to happen in conversations as we continue, that are open and transparent and collaborative, and seeking input from multiple people with their different experiences on this, and then trying to come up with a pathway that is a good path forward, that builds on some of the things that may have been what people didn't immediately see as positive outcomes of a pandemic, but as positive learnings from a pandemic, I think. And so I think at CCSO, we've started looking at some of these pieces. We've done quite a bit of work on the HR front before, and we're keen to share some of our analysis as the work continues, and especially if OH is going to be having some look at this, an eye on this going forward as well. We'll be happy to make sure that we're working on that together.
That's much appreciated. No, we'll look forward to working with CCSO and sharing data and having lots of conversations.
Yeah, and I'll just remind people to do the survey that we'll put up. And I guess just to build on what your comment was as well, Chris, is here's the challenge of trying to transform how we deliver critical care and not be disingenuous when we implemented some of these team models and things, and we said this was only for the pandemic. And I think everyone's saying, well, are you going to leave it afterwards? So there's that air of, were we being disingenuous? I do think there will be changes in how critical care is provided and delivered. And that involves everyone from physicians, nurses, to information technology and location as well. And so it's going to be hard to achieve that and not alienate various groups and people feel betrayed that what we said one way is not going to be delivered. So I don't have an easy answer for you, although I think you're right that there will be changes and opportunities for us to change what we do to allow increased productivity on the others. I guess my final question is going to be is, are there going to be incentives from Ontario Health or the government that you foresee to help catch up in the backlog, or are we just going to almost do just a start over, try to create a better, more efficient system, or is it going to likely be a combination of the above?
Yeah, I think likely a combination of the above. A few months ago, you may recall that there was I think it was a 20% incentive for centers that sort of surpassed 50% of their funded volumes. They'd get a 20% premium for every extra case they did above that, and that was intended to pay for basically after hours and weekend work. So we may see something like that again from the government. But as I say, I sometimes feel like I'm alone in the wilderness on this, but I think once we start doing procedures again and they're off listed and we see what their wait time actually was, because we've done such a good job, I think, overall prioritizing the high priority procedures, and the backlog is largely stuff that is the cataracts and hernias and hips and knees and so on, that recovering from the backlog may not be as completely horrifically impossible sounding as it appears. So I hope I'm not wrong about that, but I'm not so sure that 2 years from now we won't look back and say we're kind of back at steady state.
Well, if you're in the wilderness, I think I'm out there with you, and I'll help address the sumac issue that you were telling me earlier about with you in the bush, because I do think the backlog isn't exactly what the newspapers and everyone try to make out. My final thought before going to Bernard for the closing is that 20% incentive that you alluded to. That's a double-edged sword, because that 20% often goes to the hospitals, and that, but it also frustrates, I think, some of the average working person who feels like the average nurse or the one who's actually contributing more to allow it to happen. And I understand the benefit of it, but I also see there can be negative repercussions. And I think if we're all in this together, maybe those incentives we need to revisit and see how we do it so that one group isn't disadvantaged, especially if they were harder hit and can't increase their production. Is it really fair that then they lose out on that? So I don't expect you have an answer for that, but anytime you have an incentive, there's a downside to those who don't get it. But that was my thought on that when I heard that. So I'll leave that for either you to comment, or we'll go to Bernard for closing comments.
I'll just say very quickly in 10 seconds, I agree. For every sort of incentive, there's a downside somewhere else in the system, right? There's that balloon effect. You squeeze the balloon somewhere and it pops up somewhere else. So I think we have to be very mindful of that. And we also have to be really mindful of the degree of burnout and moral distress, and that people need a break. So we've asked a lot of the healthcare workforce, and we're going to be asking more of them, but it has to be done extremely thoughtfully.
Great, Chris, thank you so much for being able to participate today and be present for your presentation, but also for the discussion. And we know it's like this is not a easy task, this whole issue of sort of getting back to what a steady state might be, and sort of ebbing, some of the things, activities as the COVID numbers decrease, but also then trying to balance that with reopening and getting back to other services that people are keen to both start providing and that patients are keen to accessing again. And so we appreciate that there's no hard and fast black and white to some of this, but I think one of the keys coming out of this is that people are having thoughtful conversations and discussions about it, and thoughtful sort of planning around this. And I think that's going to be one of the strong elements going forward in terms of people seeing that there's some transparency to it and what the plans are. And as we sort of alluded to, there will be some who will believe that some things are not as fair as they would, through their eyes, would like to see as fair. But if we keep this focused on sort of the access for patients and the quality of care for patients, that hopefully can put us in good stead, along with being as transparent and collaborative as we can be going forward. And I get that sense that that's what will exist there. So thank you very much for being able to have the time to share with us today. I want to thank Dave and the rest of the OC3PR committee for their time and dedication to hosting and putting on yet another session. And our team at CCSO, who are always diligent in the background and making sure that this runs technically very smoothly, but also is coordinated very well for the participants who have registered to join with us today. If you have a few moments for the participants to fill out a survey, it would be very helpful. And any suggestion on future topics that you might want to suggest that we could consider, then that is also very welcome. And we hope that most of the questions were answered today. If there's any lingering questions after this, then please don't hesitate to submit them to our CCSO at our info@ccso.ca, and we can endeavor to try to answer further questions from there. And I believe we have an upcoming session planned for our next topic, which is going to be on ECMO. So it's ECLS for COVID-19 patients, our Ontario experience, and that's actually coming up quite soon, June 3rd, from 2 to 3 p.m. And there'll be information going out about that. And so I think that's it I have to close. We're just a couple minutes over, so we won't keep anybody. Thank you again, Dr. Simpson and Dr. Neilipovitz. Enjoy the rest of your day.
Thank you very much.
Take care.
You bet.